Aminoglycoside antibiotics, a class that includes agents like gentamicin, can also impair calcium channel function at the presynaptic nerve terminal, producing a syndrome similar to Lambert-Eaton. They interfere with the calcium-dependent release of acetylcholine, though through a different mechanism than antibody-mediated blockade. Clinically, this matters because aminoglycosides can unmask or worsen underlying neuromuscular transmission problems in susceptible patients. Botulism represents a completely different form of presynaptic failure. The toxin produced by Clostridium botulinum is proteolytic. It acts as an enzyme that physically cleaves and destroys specific presynaptic proteins that are part of the vesicle docking and fusion machinery. These proteins are essential for synaptic vesicles to attach to the presynaptic membrane and release their acetylcholine contents. Without them, vesicles cannot fuse, and acetylcholine cannot be released, regardless of how much calcium enters the terminal. The calcium signal arrives normally but finds nothing functional left to respond to it. Because acetylcholine is the neurotransmitter not only at neuromuscular junctions, but also at all parasympathetic cholinergic synapses, the botulinum toxin disrupts both systems simultaneously. The clinical picture, therefore, includes skeletal muscle weakness, alongside autonomic involvement, blurred vision, drooping eyelids, double vision, and large unreactive pupils. The dilated, unreactive pupils specifically reflect loss of parasympathetic constriction of the iris sphincter, confirming that the toxin is acting at cholinergic synapses throughout the nervous system, not just at the muscle. In summary, aminoglycoside basics, common agents include gentamicin, tobramycin, amikacin, streptomycin, and plasmamycin. They have broad activity against aerobic gram-negative bacilli, but no clinically relevant anaerobic activity. Their killing is concentration-dependent and rapid, with a post-antibiotic effect. Synergy can occur with cell wall active agents, such as beta-lactams or glycopeptides in selected infections. Key adverse effects are nephrotoxicity and cochlear or vestibular ototoxicity. Risk increases with prolonged therapy, renal dysfunction, volume depletion, and other nephrotoxic drugs, so renal function and drug levels are monitored during longer courses. Botulinum toxin blocks acetylcholine release at peripheral cholinergic synapses, producing bilateral cranial neuropathies, autonomic symptoms, and descending flaccid paralysis. Diagnosis is primarily clinical, and treatment should not wait for confirmatory testing. For foodborne or infant botulism, antibiotics are generally not recommended. Wound botulism may require antitoxin, wound debridement, and antibiotics for the wound or associated cellulitis, but aminoglycosides should be avoided because they may exacerbate paralysis. In the next video, we will discuss myasthenia gravis in some more detail.